Sweet. So could you give, I'm pretty sure everyone knows who you are, but a brief background and then we can just roll right into it.
Yeah, hello everybody. So my name is Mike Reiman. Like several people, wear many hats. A primary appointment is teaching in or in a DPT program. I also do research and clinically practice. I'm currently in our Division I training room where I do my clinical practice, and I like to do con ed stuff on kind of on the side. So I'll go ahead and everybody see that okay? All right, so just today what I want to kind of cover, and so first of all, thanks Chris for inviting me. Thanks everybody for coming. This is probably, like, everybody runs journal clubs differently, and so this is probably more of a kind of 1,000-point view of what's called FAI syndrome or hip impingement or whatever you want to call it. I was actually part of giving this term of FAI syndrome. It's one thing of many things that I regret. And but typically what I want to kind of really kind of go through is kind of the bigger picture and kind of really my journey. So this is actually part of my PhD. So I just, within the last 5 years, got my PhD. And so I've been a clinician for 30 years and have been teaching for about 10 to 12. And so this is kind of talking about, how how FAI syndrome came about and kind of really what it is as a diagnosis. So, and if you look at what it is the biological plausibility aspect of it is that you get this larger than normal femoral head, and then as they go into flexion, it butts up against the acetabular rim, which has the labrum. So potentially it causes subchondral bone sclerosis and labral tears and injuries and those kinds of things. And so, but there is not an absolute relationship between a larger femoral head and labral tears. And so, but where this concept really came about was from Reinhold Gans, who has since just recently passed, and he's in Switzerland, and he is world renowned in this arena, and it came about really from some things that he was seeing in surgery. So he was seeing a lot of hip patients, and he would see, and how his theory was that this would be the normal femoral head, this extra bone, what he would call extra bone, that was laid down for whatever reason, as they went through range of motion, they would butt up against the labrum and create this tearing and this impingement similar to a type 3 acromion in the shoulder. And so that's kind of really where, so this concept has been around since the 1800s, but where it really took hold is in 2003 with this article. And this is the #1 cited article as it relates to FAI syndrome. But if you look at it from a diagnosis standpoint, is you really, Judel and other colleagues have suggested, well, you really need to have like 5 things to see if somebody to really have a diagnosis label. And some people, don't even the World Health Organization doesn't even recognize some things as like piriformis syndrome is not recognized by the World Health Organization. So they suggested that we need 5 different criteria for somebody to come up with a diagnosis. And #1 is that we need to have experts get together and agree, okay, what are the signs, what are the symptoms, what type of aspects make up a diagnosis, and what should somebody have if they have that diagnosis. And so part of my PhD work actually looked at this, and this was one of the papers that I sent out, is we essentially did a Delphi study. And what we did is we asked experts in the field. So we had surgeons, biomechanists, PTs, PhD researchers, and we just asked them, what would you consider for somebody to have FAI syndrome? What subjective things would they say? What would you see in a clinical exam, and what kind of diagnostic imaging would you find? And so at Delphi, I won't go through the paper, but essentially Delphi is this fairly rigorous process where you send out questions multiple times and kind of get a consensus on what they agree on. And we'll go over what we came about. Additionally, what we did is we looked at, okay, well, that's kind of prospectively what they are kind of looking ahead, what they said, but what traditionally, what have people done to send somebody to surgery? So we looked at different surgical studies. So these are all studies that were published on surgical outcomes. And we looked at, okay, well, what were their indications for having these people go to surgery? So I think if you look at number one, I think number one has pretty much been addressed by ourselves, and other people have looked at this as well. And even if you look at another project I was fortunate enough to be on is the Warwick Agreement. And this is where we got a bunch of experts together, got to travel to England, and we sit down in a room and said, okay, what subjectively do we need? What objectively do we need? What radiographic imaging do we need? And then most recently, and this is the other article I sent to everybody, is this was, so we did relatively the same thing. This time we went to Switzerland, so the views were a little bit better. And it was a little bit colder, so we got snow. But and this time it was a project that I actually led, and we kind of looked at not only FAI syndrome, but other intra-articular pathologies, but we'll focus on FAI syndrome. So essentially, number one is, what do the experts think needs to be done or need to be included? Number two is, well, what of those categories, what is the diagnostic accuracy of those values? And this is where we published in this area as well. And we've looked at a couple of different studies on clinical exams, so Fader's test and different clinical examination measures. What is their diagnostic accuracy? And then additionally, we looked at is diagnostic imaging. You know, what did we find with diagnostic imaging? What was the values and the diagnostic accuracy, sensitivity, specificity, likelihood ratios, and those kinds of pieces of information. So number one and number two have been so 2 of the 5 have been pretty clearly met. And we've looked at what are the categories, what is their diagnostic value. And then number 3 is, okay, and 3, 4, and 5 are really important, because they kind of, I mean, you couldn't do 3 and 4 and 5 if you didn't have 1 and 2, but number 3 is looking at, okay, what patients are at higher risk? And it's almost like the StarBack tool, if you're familiar with that, is low, medium, and high risk, is like what patients are at risk, have high risk. And then number 4 and 5 is, well, do we change our treatment strategies based on those risks? And if you look at this, in my opinion, this really hasn't been done. And if you even look at StarBack tool and look at low back pain, that wasn't really done until recently. So we've, and the hip traditionally is pretty far behind literature wise from things like low back or knee or shoulder or whatever. So we're really kind of missing out on this area right now. And then number 4 is kind of based on stratification and or diagnostic accuracy, is how do we make determinations on what to do? So if we look at their clinical signs, we look at their clinical exam, and we look at their imaging, do I need advanced imaging? Do I need a CT scan? And or based on what I found is, what type of treatment strategy do I implement and do I employ? And so I'm not really sure we've implemented that either, even though, so I was involved with, again, these 2 studies. We did give recommendations on, okay, these are the findings. And then in the Warwick Agreement, we also suggest, here's some treatment strategies that we do as well. And we did that in the Swiss studies as well. But if you look at clinical practice guidelines, they're very broad and very nebulous, and they're retrospective. They aren't prospectively looking at something and, okay, we have this information based on this data, this is the next thing that we should do. So I'm not really sure that we've accomplished that goal. And then ultimately is, we know what the diagnostic value is. We've stratified them, and then we think this is the best treatment strategy. But what is the cost effectiveness of that strategy? Is, essentially is, if I have somebody that has hip impingement in this case, if their presentation is A, B, and C, is that a non-surgical treatment approach compared to somebody that has X, Y, and Z? And is that cost effective? And what's interesting is, essentially the literature is pretty much driven by the surgeons right now as far as FAI syndrome. And so the surgeons that are really good with this kind of stuff, they're already looking at cost effectiveness. And there's already at least 5 cost effectiveness studies published. And 4 of the 5 strongly suggest surgical input as a treatment strategy. But I'll give my opinion on why I think that is later. But it's like, I think we're kind of jumping ahead. And regardless of, of those 5 things with coming up with a diagnosis, is we've already moved on to a diagnosis. And so what do we have as a diagnosis, and what are the categories? And by the way, I should have mentioned this earlier, but please, I want to make this very interactive and very lighthearted. So just, stop me and ask questions if you have questions. But the Warwick Agreement pretty much says, well, okay, we need a subjective report on certain things, we need clinical signs on certain things, and we need radiographic imaging. And we do suggest that possibly advanced imaging, so that does kind of meet category 4 to some degree. So what is that? What's out there? Well, in our Delphi study, we asked, well, what do you got? What do the experts suggest as far as categories for somebody that has FAI syndrome? And the things that they suggested were deep groin pain, pain with flexion, pain with internal rotation, kind of the stiffness kind of thing. So then we looked at our Peter study, which was retrospective, and it's okay, well, of these categories, which ones are actually being utilized? And essentially the big one is symptomatic hip pain, which truly does not differentiate intra-articular versus extra-articular, let alone a specific pathology. I mean, it's just very nebulous symptomatic hip pain. Is that even coming from the hip, right? Is it coming from the lumbar spine? And so, and these were categories or in surgical indications. These are what the surgeons utilized as, okay, this is why this person is going to go to surgery, because they have symptomatic hip pain. And only 14% of it actually was truly mechanical hip pain, which in my opinion is somewhat of a concern. What is the diagnostic value of these categories? And simply, we do not know. And if you look at the literature, there are no studies published on diagnostic accuracy, likelihood ratios, or that kind of stuff on symptoms from FAI syndrome. There are a few studies where you can calculate it, and it's mostly sensitive values, meaning screening and ruling out, but there's very little diagnostic accuracy in this area. So subjective exam is very limited, even though I think many of us would agree that subjective exam is hugely important in determining a diagnosis and or even a prognosis, but there's very limited literature published to this day. So let's look at the physical exam, which is where most surgeons and surgical studies tend to focus. So what was suggested in the Delphi study? They suggested limited internal rotation with hip flexion, limited internal rotation with pain, limited painful hip flexion, and range of motion loss. What has been utilized is essentially kind of the same thing. So limited internal rotation, limited flexion and IR, which kind of is the Fader's test position. But if you look at 1/3 of them, it was this non-specific hip pain, which, I mean, if you look at low back pain, that's 85% of people with low back pain. And so, are we going down the same route as some things that we've already learned? What is the diagnostic value? Well, number one is there are no diagnostic values as far as sensitivity and specificity. So we need to look at, well, what are the range of motion limitations in these individuals? And there's been 2 systematic reviews that were published on people with FAI syndrome, and they were a year apart. One of them suggested that range of motion limitations were present in people that had FAI syndrome, and one suggested that they are not present. And so, and it's interesting is because there was only a few more studies in this later one. But then let's look at, well, okay, that's not conclusive. So let's look at different studies that have looked at specific kind of groups of categories. And these were things where, okay, well, if somebody does have a large femoral head, the premise is if somebody has a large femoral head, that's going to limit the range of motion because that bone is going to butt up against the acetabulum with flexion and internal rotation. But Igor Tak and Joanne Kemp's group showed that actually that's not the case. Now, some studies have shown that, and so this is somewhat of a biased report on my part here. But if you really look at different studies, especially the one by Krautler, has shown it's not really the the large femoral head that tends to limit the range of motion. More it tends to be the torsion of the femur. For example, a retrotorsion would give a lot of external rotation and very limited internal rotation, very similar to the shoulder. And so that they are suggesting that the range of motion limitations, especially internal rotation, are more likely due to torsion versus a cam. And of course, in that case, that's less of a surgical case than if it's a cam. Now, obviously, you could do derotation osteotomies and those kinds of things, but that's a much higher level of surgery. And then if you really look at sports specifically, and if you look at hockey players, the only significant limitation noted in hockey players was external rotation. The only limitation on range of motion on American football players was internal rotation. And in my opinion, I mean, I think you're really looking at said principle, right? What are the demands of the sport? We've already learned this from the shoulder. We've learned this from Crockett's study. And, Crockett looked at people that threw a baseball versus those that hardly ever threw a baseball. And he found that people that threw a baseball had retrotorsion of their humerus. That's why they got a ton of external rotation. People that did not throw a baseball did not have that. And so I think we really need to look at, well, what are the demands of the sport and categorize these people individually. Hockey players are not going to have the same limitations as American football players or soccer players. And then so subjective exam is not overly impressive. Looking at range of motion is not overly impressive. Most people tend to focus on special tests. And so what was suggested, by far the most suggested was Fader's test, flexion to 90 degrees, adduction over pressure, and internal rotation over pressure. Does that recreate that individual's pain? And then if you look at what was used as a surgical criteria, that was by far and away the most common special test utilized. Some people call it Fader's test. Some people call it positive impingement test. Much less commonly utilized was Faber's, or things like log roll, or McCarthy's test is, kind of like a modified Thomas test. So Fader's test is by far the most suggested, is by far the most utilized. What is its diagnostic value? Well, if you look at this, was from our systematic review in 2015, and part of the issue is right here. Use your pretest probability, meaning the probability that somebody has that condition before doing the test is 90%. So you're running into this very large potential for what's called a ceiling effect. Essentially, if I have a positive test, I can only improve by 10%, right? And so, but if you look at the values, if I do Fader's test and it recreates concordant deep-seated groin pain, I only had a very small shift in ability, meaning the probability prior to after hardly ever shifted. And in fact, if you put numbers to it, it did not even change. The percentage did not change at all. It went from 90% probability to 90% probability. In other words, if I get a positive test, I have no idea what that means. I mean, it is no value to me. And we'll talk about why some of these can be a concern. Now, if you look at a negative test on the surface, if you look at Jaski's work, Jaski would suggest, well, that's a moderate shift in probability. And so essentially what happened is you went from 90% down to 56%. With a positive test is you want to go up towards 100. With a negative test is you want to go down towards 0. You want to help exclude or rule it out. So you want the percentages to drop. And so this is what happened. You went from 90% to 56%. You had a moderate shift. You had a good drop, a 34% drop, which is very helpful and very good. So if you look at this and so this is where my journey is so when I published this, I said, well, this is awesome. This is great. And this is really before I kind of really looked at the bigger meaning of it. And this is what we published in one of those articles that I sent to you, is if you really look at the values of it, and this was one of the 2x2 tables that was in one of those articles. Essentially what you have here is on the horizontal axis is you have magnitude of shift. So this is, is it a very small shift? Is it a small shift? Is it a moderate shift? Or is it a large shift? And those are simply based on likelihood ratios, positive and or negative likelihood ratios. So if you're familiar with Jaski's work, and or even percentages could do this as well. And then on the y-axis is you have precision. And I explained this a lot more in that paper, but essentially precision is how precise or how much does that post-test probability, how much does it vary? And it's strongly based on confidence intervals. So if I have very wide confidence intervals, I have very poor precision. It's very imprecise. And essentially that's what you have with a negative Faders test. Because if you looked at it, so here's the negative Faders test. If you had a negative Faders test and I plotted it based on magnitude alone, it would be, so this is kind of like the stoplight. These are tests you don't want to have. These are tests where you want to be cautious. And these are good tests that you probably want to utilize in your clinical practice. If I look at a negative Faders test with a surgery reference standard, if I looked at magnitude only, which is what I did in a 2015 study, I would have plotted it up here because the magnitude was moderate. But here's where you need to look at multiple things is, well, study quality as well. And I won't go through all of this, but so it's mostly low quality studies, which is a concern as well. The concern I'm trying to point out here is so you went from 90% to 56%. You had a 34% drop. But the confidence interval was anywhere from 5 to 95%. So you could have dropped from 90% to 5%, which would have been pretty much they don't have it. Or it could have actually gotten worse and went from 90 to 95, which is what you don't want with a negative test. So the effect is very imprecise. And that's why it drops down into this yellow quadrant. And we probably need this is just the next iteration and probably need something better because to me, that imprecision probably drives the effect even harder. And I mean, it's in the yellow quadrant where you just need to be cautious. I would suggest, like, a positive Faders test in an orthopedic surgeon's office is not helpful. I'm not even sure a negative test is helpful. And, well, number one, it happens very rarely because the pretest probability is so high. And it's, if you think about these patients, they've had this problem for 2 or 3 years. They've seen, they've already tried rehab. They've tried these different things. And so they kind of self-select and come down. If the ones that aren't getting well, they go see the surgeon. I mean, literally, I could walk into the surgeon that I work with. I could probably walk into his office, and 9 out of those 10 individuals probably have intra-articular pathology because the system has farmed them down and kind of excluded them as they went through the process. But here is a good example of how precision is very important. So with special tests for the FAI syndrome is you have concerns about low quality studies, you have concerns about precision, and you have concerns about sorry, ceiling choking me up. You have concerns about ceiling effects. So low quality studies, poor precision, and ceiling effect. So special tests are not very special. And you've probably heard multiple people say this before. And unfortunately, this is what most of the surgeons are utilizing as part of their diagnostic criteria and or determination of going to surgery. Well, so let's try to look at some other things and see if we can find something that is really helpful to us.
Hey, Mike.
Yeah.
A quick question. Do you think that this reliance on special tests, do you think it's driven truly by the decision tree, that it's actually inherently helpful, or do you think that it's one of the check boxes that they need to justify surgery with insurance?
Yeah, Paul, that's a good question. The short answer is I don't know. I think, well, like every surgeon I've hung around with is here's how it goes, is they're very busy. They're jumping from room to room. The PA goes in and does a subjective exam. They pull up the radiographs. Everybody has radiographs before they even see them. And which, I mean, that's a whole other story. And so they pop up the radiographs and they see this large femoral head and they go, large femoral head, FAI syndrome. And then they get the subjective history. And I'm not even sure any subjective history registers with them. And so then they go in there, they show the radiographs, the patient sees what that type 3 acromion, that large femoral head, like, what the hell is that doing there? Get that off, right? And so then they say, well, okay, when I put you in these positions, that's why it hurts, because it's jamming up against there. I think special tests, I mean, all they are really is modifications of range of motion and manual muscle performance testing, right? I mean, that's typically all they really are. And like I tend to teach my students is, like, you really don't have to do hardly any special tests, because you've already looked at range of motion, you've looked at muscle performance, and you've already, like, drop arm test and all the rotator cuff tests, you've already measured that. Why are you doing them? And so I think it's in a physician's practice is they don't look at those things. So I think that's an easy thing to do, is my opinion. And here's where I would like to see us kind of go, is to physical performance measures. So, looking at things like a squat. So FAI did this nice study where he had people do what he called a maximal squat. And when I saw this study, I go, this is it. This was published, I think, in 2014, and we wrote about it in 2017. And there's only been really one study on that's looked at it and the value of it. So the positive things is now your probability is very low. So you don't have a ceiling effect. This is ideally what you want, is you want a relatively low or kind of a midpoint pretest probability. So on the surface, this looks really good, because they didn't take only patients that had a high prevalence of FAI syndrome. So this has a good probability of shifting high and or low. But even then, with a positive test, is you only had a 6% shift, which according to Jaski's work is a very small shift. Any negative test was essentially the same thing. It did not shift your probability. Anecdotally, I use this as a big measure in my clinical exam. And if you look at the study, and FAI has done a ton of great work. He actually just published a recent placebo-controlled trial on FAI syndrome. And I think they didn't standardize the way people squat. And I think that's something that I tend to do. And I will have people squat as they traditionally squat, sumo squat, knock, and like I'll do a bunch of different things. And I think just simply doing it one way is not exactly the best way. So then when most people and most surgeons tend to look at is diagnostic imaging. And the things that were suggested were a ton of them. And so much, in fact, that we had to pull this out separately and utilize this as a subcategory. But most people will tend to look at what's called an alpha angle, which essentially is how big is that bump on the femoral head, and when does it kind of no longer make this head round. And so, I mean, it's a little bit more than that, but essentially, if the bump was clear up here, you'd have a much larger alpha angle. And if there's more bump, it's more likely to butt up against the femoral head or the acetabulum. And then there's, well, okay, well, what does that angle need? What does that measurement, what does this need to be bad? And I think anytime you go dichotomous is always a problem, right? And so, but what was published in different surgical studies is, over half of the studies suggest, well, you need greater than a 50-degree angle. And that's what some of the original studies suggested. But then if you look at population studies, there's tons of people that have, like probably the majority of us on here have an alpha angle greater than 50 degrees. So then they shifted it. And only 3% of those studies suggested it need to be higher than 60 degrees. And then myself and Rinchi Agricole and some of our colleagues, we published based on population studies, well, what do we suggest that number needs to be? And we suggested it probably needs to be at least 60 degrees. And so, so based on this alone, you can make an argument that a lot of people with lower alpha angles went to surgery. And if you look at the diagnostic values, is even diagnostic imaging really only has small to large shifts, and it depends on the imaging. The imaging with the best value is MRA at 3.0 Tesla, and it's mostly for labral tears. There's very limited imaging that shifts your decision making, like on number 4 suggested. Because remember, with imaging, is you want to, after you do your clinical exam, is do I need more information? And if I need more information, is that really going to shift my probability in my decision making? And if you look at radiographs alone for FAI, I don't think you can make that argument. So then the question comes is, why do we have all these issues? Why is this not very clear cut? Why are all these problems? Well, let's go back to the original study, and well, not necessarily the original study, but the one that was the most popular. And if you look at the original GAN study, they published a couple of years ago. They published the top 50 cited articles as it relates to FAI syndrome, and this is number 1. And this is by far, and I mean, it's like by far, and every time you have an article on FAI syndrome, this thing is cited. Now, let me kind of go back here a little bit. And so, I mean, I think that's a concern. Why do I think that's a concern? Well, a couple of things. The rate of FAI surgery between 2007, over a 7-year period from 2007 to 2014, increased by 2,600%, 26-fold. So in 2007, I mean, it increased by 2,600%, which is far, I mean, it's 3 to 4 times higher than any other rate of growth of surgery. I mean, if you look at subacromial impingement syndrome, that rate of growth was 700%, and that was the next highest. But let's keep looking at subacromial impingement. If you look at the literature currently on subacromial impingement, where that whole concept came into play, really, where it came into notoriety, is Charles Neer published an article saying, here's what I'm seeing in surgery, which is exactly what GANS did. And if you look at Neer's, it is by far the most cited article that's published out there. And it's not based on diagnostic accuracy. It's not truly based on, I would argue it's not truly based on biological plausibility. And if you look at those studies, those top 50 studies, only 5% of them are biomechanical studies. If you look at some of those biomechanical studies, some people are impinging at 40 degrees of hip flexion, yet they're still able to sit in a chair, they're still able to do squats. Like, I think this is a big issue. And so the rate of growth for FAI syndrome in surgery is exploding. And sometimes when you have growth, is you have painful growth. And I don't think we're necessarily learning from, the shoulder or whatever. And, the other thing is, well, is it a diagnosis problem? Because if you really look at the diagnostic values, I mean, like I pointed out, they're really, really small shifts, and or large if you look at 3 Tesla imaging. Do we really, common sense or biological plausibility would say, well, we need to go back, and because in order for something to have a diagnosis, it needs to make biological plausible sense. And the problem with that is it's too late. The train has left the station. The rate of surgery is going so high, and part of that rate is 700 to 900% of that growth is new surgeons coming in. This is a very attractive surgical procedure, and you're getting a lot of new people into it, and if you look at the outcomes on new surgeons, the outcomes aren't near as good, and the complications are a little bit higher. And the other thing is, well, because ideally what I would suggest is what we look at is, because the problem with doing these diagnostic accuracy studies on people that have a high pretest probability is it doesn't change your probability, and or it's very imprecise, because that's what multiple studies have shown. What the suggestion probably would be is, well, let's go to like a family practice office where you have all kinds of hip patients, OA, adductor. I mean, people that do or don't have adductor tendinopathy and those kinds of things, and let's do it there. The problem is it would take you forever to do that because they don't have very many of those patients. And then the other thing is this has already been done. This was a study by Nicola Casertelli out of Germany and Switzerland. And what they did is they looked at diagnostic accuracy of Feder's test in youth hockey players that were asymptomatic. And the diagnostic values were worse than they were for the people that had pathology. So I'm not sure, like I'm not sure what we do with that information, to be honest. And then the other thing is like, what are we assessing, right? If you look at NIRS test, like what are you, if they have pain, is that truly impinging? Currently, studies are showing that people that have subacromial decompressions versus those that don't at 10 years, there's no difference, right? And I mean, some newer studies actually suggesting, well, actually there is. And then in hip impingement is, are you truly impinging the femoral head against the acetabulum? Are you impinging the psoas? Or, I mean, like I've had multiple patients that don't let me get in that position because they know it's going to hurt. So, I mean, are they psychologically, I mean, is it a psychological component as well? And then kind of along those lines is, are we assessing everything that needs to be assessed? If you look at outcome studies, which are tending to drive the literature right now in FAI syndrome, there's been several studies, and Dan Ron and Chad Cook have published on this, showing that if people had mental comorbidities prior to surgery, those actually exacerbated after surgery. So surgery did not cause those mental comorbidities, they just made them worse. And then from somebody that's getting a PhD or that got a PhD on diagnosis, does the diagnosis truly matter, right? Because looking at the data I presented, you would say, well, crap, does it even matter if I do Feder's test, right? And then, you know, a bunch of people are pushing prognosis and or response to treatment type of approaches. And I think one thing really quick on prognosis is there's a lot of issues with prognosis, and I won't get into that right now. We can later if you're interested. But if you look at response to treatment, if you look at it from a standpoint of a research standpoint, those are very tough studies to do, you know, and so those are very challenging. And if you look at it from a practice standpoint, is my suggestion would be is why not just do good clinical practice, right? Because and know how to, because I think what happens if you look at the literature, and we published, this is one of the studies we published in the Swiss group, is our suggestion was these patients are probably not pushed or loaded as hard as they need to be. And I think the other thing is just, you know, I do a continuing education course on different hip pathologies, and I just think people are scared to work these people the way they need to be worked and or load them enough. And I mean, I've done this too, is, I mean, they have pain with doing something. Okay, well, don't do that, versus finding an alternative way to do that. And so I think if we did good clinical practice and exhausted good clinical non-surgical rehab in the patients that don't respond to that, yeah, those people probably need surgery. And so that's, I mean, that's currently my approach is patients come in, we still do squats, we still do all these kinds of things, but you know, we don't, I mean, they're probably coming in because they have pain with a low bar back squat. So we go to a Smith frame squat, or we do a squat with, you know, pulling or some, you know, something like this, or we do a box squat, or we do short of the range of motion and doing tempo. I mean, we still load them, we just load them in shorter ranges or different positions or whatever. And if they don't respond to that, yeah, they probably need to go to surgery. So kind of in conclusion here is, you know, I think the big thing with this whole thing is, you know, I've learned a lot, and I've learned that I still think a diagnosis is important. I still think doing Feder's test is important. Just the interpretation of it, I'm not sure what I take into account. If it's somebody that's had pain for 2 or 3 years, like I may not even do a Feder's test. I'll probably just have them do different squats and see if a sumo squat feels better than a traditional squat. And then I may not necessarily put a lot of weight into what their diagnosis is versus just treating what feels better to them. And so, but if you look across the board, is there are different limitations to FAI syndrome diagnosis. but I don't think that should change how we do our rehab and address them. So.
That was great. Thank you so much, Mike. I've got a lot of questions. So the first one, how long will you try non-surgical management until you recommend surgery, or is it totally up to how long the patient wants to continue?
That's a great question, Chris. I think in the so in one of those studies, so in a Swiss group, we published 4 studies, and one of those groups, Joanne Kemp led, and and we all suggested that probably needs 3 months, but it needs 3 months with proper loading. Now that said, is I've had patients come in and I think after 2 visits, it's yeah, you need to go to surgery. I think it's one of those where if you have experience in this area and you know, like for example, the patients that I tend to send back right away is they have mechanical symptoms and they click and they catch no matter how I change their positions. And it's getting to the point where it's affecting everything. Those patients up and they've had PT before. But I tend to, I think as rehab specialists, we tend to hold on to people too long and or send them too soon. And there's always not a good way to decide, but I think a good trial of hopefully 3 months could be a good option.
All right, I'll ask another one. If they do end up getting surgery, what does that timeline to return to normalcy look like? Or does that just depend on if they're, playing sports or if it's just ADLs?
Yeah, so what's interesting is, we published, and other people have as well, we published a systematic review on 35 studies for return to sport, and the average time frame was about 7.5 months, and this was for FAI with labral tear. In my opinion, that's a little bit fast. I think it's fairly analogous to an ACL, maybe just a little bit quicker. But then, another study out of Denmark showed the same time frame is like only 17% of those people went back to sport. So I think it depends. Like what we know is the more elite tend, it's like, it makes sense. The more elite tend to go back faster, have better outcomes than the non-elite. But like I tend to, that 6 to 9 month time frame is when we're doing return to sport activities with a goal of sometime after 9 months and or 8 months of getting back to their sport. Another very interesting study out of Denmark showed that, and these were non-athletic, non-sports people, but athletic people, that only the people felt better and they had better patient-reported outcome measures 1 year after surgery, but they were not as active as they were prior to surgery. So that's a part of this. If you look at the outcome studies, it's very interesting because if you look at their patient-reported outcome measures, the majority of them are about 80%, meaning out of 100% is they're good to go, everything's great. Most of these studies, these people are at 80 to 85%, and they tend to be less active than they were prior, but they're satisfied. So it's like I'm not sure what that all says. Are they just like, okay, I'm content, I've dealt with this for 3 years, I've had surgery, like this is what it's going to be, and I'm not sure what that all says.
With the patient-reported outcome measures, do you use those in clinic or find them valuable, or is it not really providing much information to you?
I think that's a really good question, and probably depends on the day of the week you ask me. It's with the understanding that one of my PhD advisors invented the Hagos. I do use a Hagos. I think it's the problem is I think patients get very numb to this, and patients get tired of filling these things out. Where I'm at is we make them fill out a GROC every time they come in a pain report. It's like that's part of their standardization. I think one thing that's nice about it is it gives the patient a voice. And so that's something that could be reflective. I think one reason I like to do it is like they might say, on their thing, they're saying that they're doing really well, but they tell me subjectively they're not. And I say, well, here you're saying this, subjectively you're telling me this, like, can you explain that? And so as a general thing, like, I'm not a huge fan, but I do think there are aspects that can be very helpful, as I mentioned there.
Do you see Ben's question?
Yeah, we are covering. Yeah. Well, so I teach DPT students as well, and I teach them. I mean, I'll just be honest. Like, I teach them some things I don't think need to be taught, but I frame it like for example, the SI joint. I wrote a chapter in my book, and I said, before you take your boards, just read that chapter. We're not covering it in an MSK class, and yeah, I think another argument too is if you're going to say, okay, this stuff doesn't work, is you got to know what that stuff is, right? Like, you have to know how to do those tests, what it feels like when you're doing those kind of things. So I think as a student, it's important to understand and learn it, but also it needs to be framed with what its limitations are, right? And so I'm not sure that gets at your answer, Ben, but like, I teach Fader's test, but I spend a lot of time. I mean, I essentially go over a little bit more detail than I did here today, and saying why it's limited and what it means, and the fact that it's in bias studies. So, but yeah, I mean, I also teach them not to do a lot of special tests, and how you use the overall comprehensive. It's a small component of a good comprehensive exam, and it needs to be used accordingly.
Mike, with the big meeting room you had in England and then in Switzerland, one, what was that dynamic like? And then two, what was the biggest disagreement that the group had?
No, they were both awesome. And the Warwick one, I kind of went with, well, I'm just going to kind of sit back and listen. And there was a lot of disagreement, which honestly I think is very good. I think it's very important. Well, number one is, so Damien Griffin, who's a England surgeon, put it together. And to Damien's credit, is he had PTs there, he had researchers there, he had surgeons there, and it wasn't just all surgeons, which he had radiologists there, which we did in Switzerland as well. And like, the group that I hang out with, which is kind of Per Homick and Christian Thorberg and those individuals, like, they had a lot of disagreements with Damien. And but I think that's good. Get that stuff on the table and say, well, like, okay, why do we disagree in those kinds of things? And so, like, yeah, it took a lot longer. Like, I would like to see more of this, this kind of stuff where we get in and say, well, here's why I'm thinking this. The nice thing about it is everybody did a nice job of saying, well, okay, from what my understanding is, what you're saying is this, and understanding that. And then they would say, well, I still disagree. And then so we would try to come up, and that's what typically happens on practice guidelines. They tend to be neutral language, because if Damien wrote it, it would have been this way. If Per wrote it, it probably would have been a different way. And it needs to be where it's across the board. Now, in the Swiss group, I couldn't sit back because I was leading. And so, I had led I was a token leader, because essentially I'd put it out there and everybody would argue, and I'd say, okay, well, we got to move on. We need to come to some agreement. And because it was fascinating. It was really good. And it was really good for people with hip pain patients.
Kenny had a question, and I was going to ask something similar, but he said, you mentioned a few of the regressions and modifications you use for those that have FAI symptoms. Could you touch on the ones you utilize most often and have found success with? And my question to add on to that was going to be, someone came in with, FAI, or your interpretation of whatever that would look like. what would be your initial plate? Like if you have them do a squat, what would your initial like next step be? Would it be like reduce load, change stance width, etc.? So
Yeah, I mean, those are great questions. I mean, and those are clinically practical. So typically, number one is they come to me from the surgeon. The surgeon has already told them, has showed them their radiographs, and the patient comes in and says, like, why am I here? I mean, because I mean, it's like, what are you going to do for that bone? I mean, have you seen my radiographs? And I go, yes, I've seen your radiographs. And then the next thing I typically do after subjective history is, okay, let's use, dude, I just told you squatting hurts. Like what? And they're like ready to leave. And so, and I say, I understand that squatting hurts. What I'm trying to see is what kind of positions are you sensitive in? And I tend to use the term sensitive or something like I don't use impingement. I don't talk about bony abutment, any of that kind of stuff. And then where I tend to win them over usually is changing their stance, tempo, short range, or whatever. So like one of my first go-tos is changing stance, going to sumo squat. It doesn't always, sometimes people that are unstable, it tends to make them worse. So then we go to a Smith frame or a front rack squat or a box squat and using tempo. And I think the variables that I tend to play with are, stance, range of motion, tempo. I mean, those are probably the first three things I go to. I mean, sometimes I'll have them squat, and like that picture I showed where the cable column is pulling them out or the belt. I used to do that a lot, but then the problem is the patient, well, how am I going to do this at home? And so then, I mean, they can get voodoo bands and put it on, but if you look at the studies, there's no way that hip is distracting. Like, I don't know what it does, but it seems to work a lot. And so like, I'll play with that a little bit, but I tend to use it more to kind of recruit the gluteus medius and maximus. And I mean, they feel good. So they say, well, how can I do this at home? And so that's what I'll give them. But the things that are, I always look at, well, what is easy for them to change and do at home? So it's stance, it's tempo, it's range of motion, it's, wall squats, like a Smith frame squat or something like that. Or go to lunge or something, you're changing something like that.
And then Jordan asked, I've seen a lot of people's go-to for treating FAI is adding some sort of lateral distraction in various positions. Do you utilize this? Is this a short-term solution? And that's kind of exactly what you're talking about right now, I'm assuming.
Yeah, I mean, it's so like I used to do a lot more with voodoo bands because I mean, it's like we all go through phases. Well, that's pretty cool. Let's try it. And then it feels good. And I go, oh shit, like how are they going to do this at home? Yeah. And so, I think, I mean, you always have to be careful because like what I want is no matter who I'm treating is like, okay, how can they replicate this at home and try to do this? So like if I spend a lot of time mobilizing somebody, which I've gone away from, like how are they going to mobilize their shoulder or their hip or whatever? So, but yeah, I mean, I'll be honest, like I use the cable column a lot and I try to load it really heavy so it almost pulls them over. And like I like to do squats with the cable column, and it's more to get them to abduct closed chain and externally rotate closed chain to try to get closed chain glute med and glute max to fire. And I mean, then they recognize, well, there's no way I can do this at home. This is something we're just going to do in the clinic. And or if they're an athlete, then the problem with if they really like that is how do you have them do that safely at home? Because like I load them to where like it pulls them over and I have to push them back because I think you need a very heavy load. And so, but I'm careful on who I do that with. And it's like, we don't do that early. We do that after we've, got good therapeutic alliance, good buy-in and all that kind of stuff. So.
They have bilateral FAI. Will you double up on column on each side, or what does that look like?
Well, we do have, so it's like I'm in a training room, so like we have everything. And so, yeah, I will. But that's typically just with athletes, right? And which sometimes can be worse, right? Because then they feel like they can do whatever they want on their own. But probably for a traditional outpatient patient, I would probably go one at a time. And or maybe just try one, probably the one that hurts the least, and try it first. And then a couple times that does fine, then try the other one as well.
Then do you notice any patterns in individuals that present with FAI risk factors like demographic, recent loading patterns, et cetera?
Yeah, that's a really good. So Chad Cook and I and a surgeon I work with, we did this study, and it was a telehealth study. I mean, which, like, I'll get to the answer here. But so we did this telehealth study, which essentially we tried to compare an exam with a clinician doing it versus having the patients do it on themselves. So, like, we taught them how to do sit to stand, their own Feder's test, and this kind of stuff. And essentially, the long story short is they were both pretty bad as far as diagnostic accuracy, but it was a pilot study. And so we were trying to show proof of concept, which showed that you could potentially do it as a telehealth exam. Digging into that data a little bit deeper, what we think we found, but, and again, it's way underpowered to look at this, but like, I do think these people are different. I do think you have, and I don't know if, I know Steve George is coming on next week. I don't know if he's going to talk about phenotypes and that kind of stuff, but I don't know if Chad did. But I mean, if you look at low back pain, people are looking at phenotypes. I do think you do have different hip pain patients. Number one, I think patients with impingement that are dysplasic, they are way different versus somebody like me that is very, Bain score of 0, very tight jointed. Those are different individuals. So in that aspect is, I think you can't treat them all the same. I think you do have to look at people individually, distinctly different. I do think there are people that are, so what's nice is there's some studies, well, it's not studies, it's recommendations. And they talk about sports. And in that study, they talk about pivoting sports, impingement type of sports, rotation type sports. For example, female baseball, softball players, their back leg, I tend to see them have a lot of laxity, but they still impinge. I would treat that person differently than, even on the same team, the softball, the catcher that's in a sustained squat position with limited range of motion. Like, those are two different people. And so I think where you do a good clinical exam looking at range of motion and, how much range of motion do they have, is a different, comparing internal versus external rotation. You do have different presentations, and I think you need to address them appropriately.
How would you treat those two differently?
So on my the batter with laxity, it's all short range of motion. And so it's, number one is, don't take the activity away from them. So if we're doing standing, closed chain rotation stuff, but it's in a very short range of motion. And it's probably holding the cable column like this and doing short ranges and just doing tons of repetitions. And there's a lot more to it, but on the softball, the catcher, it's doing tempo squats to a box, and it's trying to tolerate the sensitivity of getting into that position. Because really, if you look at, here's what I talk about with all my patients, because they come in and they say, well, Mike, I mean, what can you do for that bone on my femoral head? And I say, absolutely nothing. And they go, well, why am I here? And I say, well, let me tell you about what I know about the literature. And what we know is, it seems to be that femoral head shapes as you grow. And the more you load it, the growth plate, like, I don't go into this detail, but the femoral head shifts on the growth plate. And that tends to not grow after the growth plate is closed. So if they're 25 or 24 or whatever, and they're a female, the growth plate probably closed at 14 or 15, somewhere in there. So why do they have problems 10 years later? And so that's what I point out is, and the other thing is, since I can't do anything about that bone, the things that I can do is look at your training program. Are you squatting more? Did you play more games this week? Did you, if they're the catcher, are you catching more games? Are you, what have you done differently? And looking back on it. The problem is, and I get a lot of these patients too, is if they've had pain for 2 or 3 years, like, they can't remember. And so then that approach, I say, is, well, okay, it doesn't matter. I mean, that was 2 or 3 years ago. Now let's look at how active you are, what bothers you, what can you tolerate, and how can we build your envelope of function up, right? And so, if they're tolerating this much activity, how do we gradually step it up? And that's typically change of position, tempo, different, volume, intensity, going 2 days a week versus 3 days a week, using things like RPE, I mean, all that kind of stuff. And so it's, I spent I spent a ton of time using education on that first visit, because I mean, if you look, I mean, I would be the same way. If I didn't, even knowing what I know, if I had a radiograph, because like my right shoulder has been bothering me, and if I had a radiograph and showed a type 3 acromion, I was like, oh crap, I'm not going overhead, I'm not doing presses and that kind of stuff. And I mean, if I didn't know, I would say, cut that thing out. Like, I mean, it's going to tear my rotator cuff. So I mean, I get it and I understand it. And so you have to acknowledge that with your patients, but you also have to frame it, right? Is you have to say that femoral head has been there for 10 years. And yeah, I mean, it may limit your range of motion, it may limit your internal rotation, it may limit these things, but there's plenty of people that have it. I mean, a study showed that 69% of people that were asymptomatic had labral tears, Jonathan Frank study. And so like I talk about those things, but I mean, you don't dismiss their pain either, right? I mean, as you say, I understand that you have pain. The good thing is there are some people that don't have pain that say have these same findings. Now, what can we do to get you back to that kind of an activity? And then as we go along, is if we're not improving, surgery is always an option, right? I mean, the nice thing is the surgeon I work with, well, he used to have a 6-week waiting list. Like, you got 6 weeks, what are you doing anyway? Give me 6 weeks.
This is probably a stupid question, but what's the difference between retroversion and retrotorsion?
Probably not. I mean, it's like, I think they're terms that are used interchangeably. And so some people, like how it makes sense to me, and how, I mean, we probably have to ask a true biomechanist, but to me is torsion should be named for what happens to the femur, version should be named for what happens to the acetabulum. But what you see is you see those terms used interchangeably. So if somebody says somebody has femoral retroversion, I mean, it's the same thing. Yeah, I mean, it makes it very confusing.
Do you have experience working with hockey goalkeepers, since that's like the position, because that's basically faders that they're doing repetitively? Do you have experience working with hockey goalkeepers in this situation?
No, I mean, I don't. But if you look at, I cited that one that one study, and their only limitation was extra rotation. I mean, it's because they're always going into rotation with butterfly, and so I think it's just simply like, I wouldn't really change my rehab a lot. Even, I mean, I probably never will work with. I mean, I'm not in those arenas, and so, but I would still look at the differences, and I would still try to get them, if they had pain with internal rotation. Is the problem is, if they're very experienced, they either change their technique, which is going to take a lot of time and not be a good thing, or you try to get them less sensitive to that position over a period of time. And so, doing less, going, I mean, I can't even speak intelligently on this, but doing less task, and doing it less frequently during the week or whatever. So my approach would be generally the same, just different motions and stuff.
Do you think like 10 years down the road, FAI just isn't going to be the terminology anymore? Kind of like the shoulder impingement example?
I mean, I hope so. I mean, it's we all, like, there's a lot of things I regret publishing and or doing. And it's, I mean, at the time it made a ton of sense, right? And so we published, Christian Thorberg and I published this thing in British Journal of Sports Medicine. And we were kind of, our point was, we think surgery is overdone. And we published one in JOSPT as well. And I forget, in one of those, I forget which one, we introduced the term FAI syndrome, because our thought was, well, these people are variable, they have different we didn't use the term phenotypes at the time, but they have different presentations. And the problem is there's such a negative connotation that goes with syndrome that goes, and even the impingement aspect of it is, like I said, some people impinge at 40 degrees. So yeah, I mean, I hope it comes in that. If you look at the article, the Swiss studies, what do we call it, hip related pain, and we even disagreed on that. So some people wanted hip related groin pain, and some people wanted hip related pain, which, I mean, that we argued on that for like 3 hours. So I mean, I hope it comes to something simple like hip related pain, which hopefully that article kind of gets away from the FAI syndrome.
I do find it interesting, though, that we have this idea that we have to put this label on this thing, right? And that's going to drive what we're going to do with the individual in front of us. When I don't know about you, Mike, but over the course of my career, I move much more to what can they do, right? What do they need to do? And it's all driven by task analysis and what they can't do now and how do I get them there? I could care less oftentimes about what a diagnosis is, because I've just got to be able to return to a task and know what my limitations in getting to that task are, and then integrate a pathway to that for that individual that they can execute. And it's always based off of that individual. And the diagnosis doesn't necessarily tell me a lot. Yeah, we argue a lot about terms. And what we find is when we look at these terms, there's really no agreement. And when something can be anything, it really is nothing, right? And so it's really, really hard to argue over terms when we in practice typically can only deal with what the human being in front of us can and can't do and what they need to do and how do we bridge that gap. The term doesn't really enter into my thought process.
No, I mean, it's a very valid point, Paul. And like I'll just kind of keep it brief here because well, I mean, you're in the research academy, and I talk a ton. Like we have modules on diagnosis, which is or this week, I think, and we have modules on prognosis, prediction, determination, and all the stuff you're talking about. And there's a difference if you look at it from a standpoint of research versus clinical practice, and clinical practice is always going to be different and ahead of research. And I mean, and to be honest, that patient in front of me, like, does it really matter if I mean diagnosis? Not really. Ideally, I would like to have a prognosis, but and I talk about this a lot more, is prognostic literature is not very impressive either. I mean, there's significant limitations there as well. Now, if you're comfortable with uncertainty, which, you know, we talk about that as well, you should be, but the patient isn't. I mean, if you look at the literature, is patients want to know a few things: what their diagnosis is, what are you going to do for it, what can I do for it, and is it serious? I mean, I think there's another fifth thing, but I can't remember. I mean, they always want those things. So I mean, and I've learned this the hard way. What I tend to do is I don't dismiss their diagnosis. I say, here's what you've been diagnosed with. Interestingly, is you're presenting like this. And so like, I don't dismiss that because that's important to them. It's kind of like their frame. And then, I mean, over time, then we kind of chip away at that. And it's not necessarily chip away from it, but just like relevance of it. And so kind of like the type 3 acromion or whatever. And so that's why I tend to use the term sensitive with certain motions and or whatever. And yeah, because I think, well, I mean, I don't know if I shared this in the academy, but it's like I spent a year in, so one of our fellows was in chronic pain, and the only patients he saw had chronic pain, which was a very challenging year of growth for me because that's not my typical patients that I see. I mean, I'm much more into sports medicine, but it was really good for me. And we had this one patient that, you know, we tried to channel Peter O'Sullivan and Lorimer Mosley and all these people. And because she was very resistant to talking about nociception versus pain and threat and DIMS and SIMS and all that kind of stuff. And apparently we didn't do a very good. I mean, I let her take the lead because she does this more. And long story short is the patient got up and said, you think this is all in my head, and got up and left. And she stormed down the hallway to the physician who was in the same building and demanded to be seen. physician called us in. I mean, long story is like we all got on the same page, but the patient was still never came back, and like we lost her, right? And I don't think that's a good thing either. So, but I mean, we all learn, right?
Yeah, I learned not to try to diagnose terms, right? We had a group of orthopedic surgeons when I was practicing in Lubbock early in my career, and we were all fairly recent graduates. And so we've got these toolages, right? And so we're telling people you've got a meniscal tear because these tests and all this stuff, and the doc hasn't given them that label yet, right? And this doc was actually forward thinking. He's like, I don't tell them that. I just tell them that their knee is hurting right now. They have some mechanical signs and it may be something, but we need to do this first. And so you're undermining me later, right, by saying that they have a meniscal tear. And he goes, and they may be able to rehab out of that anyhow, but now they think I have to fix it, right? Now they're going to come to me and go, this is torn and you need to do this surgery. And he was actually trying not to have to do the surgery unless they failed at the rehab. And he's like, you guys are killing my authority and you're undermining me. So stop giving them that and start talking about just this tissue is this and you can't do this, but we can work on this to do that. And that's actually early in my career where I learned that. And I learned it from a surgeon, which I just find rather interesting.
Yeah, that's very interesting. Need more of that.
I got a quick question for you, Dr. Reiman.
Please call me Mike Reed.
Okay, all right. As a second year PT student, I find it challenging to try to navigate evidence-based measures along with still trying to learn kind of regular clinical patterns and guidelines. And this is kind of piggybacking off of what Ben's question was earlier, but I'd be really interested to hear your insight and your input into what you would recommend as a student on how to navigate both the waters of learning the clinical decision making, because quite frankly, I don't really know that deeply yet either as a student, right? And then also navigating the nuance of the evidence in the literature.
Yeah, that's a great question, Reed. Well, so couple of ways again, this will probably be a long, broad, hopefully I answer the question is, so like when I teach our students, like what I struggle with is how deep do I go, right? Because we have a certain amount of time. And they also have to, I mean, to be honest, they also have to know certain things that are going to be on the boards. Like SI joint is going to be on the boards. They need to know it. And so do I spend time doing that and getting on my podium for an hour saying how we just wasted his last hour, or do we kind of try to frame it and reference it? And I don't know, I've been teaching 10 years and I change it almost every year. And well, COVID changed it a lot last year. And so I think number one, I think is they have to know what we're talking about, right? And anytime you have a disagreement or a discussion with somebody, is you have to know what that other viewpoint is. And so you have to understand that. And to know that SI joint has very little movement, has very little bit of relevance, and movement testing is terrible. Like you have to know, okay, well, what is it? Okay, here's what the STORK test is. Here's what Gainsland's test is. And so we have to spend time on that. The problem is class is only a certain amount of time and it moves quickly. And so like, I think that's good. I mean, so it's good. That's why I started the academy and other people have done other things, and there's other good things out there. But I think you also have to, well, here's another big thing is like when I went through school, like what I'm noticing is students are a lot different in a very good way. Students want to make a huge difference right away. And if you look at, no matter who you look up to, Peter Sullivan, Chad Cook, whoever, those people, like Chad Cook and I talk about this all the time. We were ding dongs our first 5 years. Like we were literally terrible. And so it takes like Simon, I don't know if you guys knew who Simon Sinek is, but it's like, I love some of the stuff he talks about. And he talks about, people your age that he consults with businesses, and he would consult with these young business people and say, man, the young business person will say, I think I'm going to leave this company. And Simon would go, well, why? He goes, well, I'm a year into it, and I'm not really making a huge difference. And I've talked to students. I mean, my daughter's in PT school, and she's seeing patients, and she's having the same lingo. And how I talk to my students is, you are making a difference. You're making a difference in that 930 patient, right? I mean, you're probably not publishing clinical practice guidelines. You're not speaking at CS. I mean, you're not doing some of the things that I'm doing, but I wasn't doing those things at your point either. Like, you need to understand this is a formative thing. It takes time, and it's okay to, I mean, if it takes you, like, honestly, I mean, and I know nobody would do this, but like, the best residents I've ever had are the ones that have been out for 2 or 3 years. And okay, Mike, I don't understand what's going on. I mean, I've seen 20 of these patients. Like, I don't understand what's going on with this. You had those discussions are way different than a new grad where, okay, let's rehab this ACL. Wow, I've seen one. Like, then here's what, I mean, because the conversations are way differently. And so I think, I'm not a huge Robin McKenzie fan, but Robin McKenzie talks about, you can never see too many patients. And I agree with that. It is like, I mean, this is why I still clinically practice. Because I've been asked to, to do more research. And I think it's important, if I'm teaching a clinical practice management class, is I need to be seeing patients. And I need to say, here's what I saw on Tuesday. What would you guys do with this? So I don't know if I'm answering your question, Reed, but I think patience is a big thing. And I think, to be honest, like, diagnostic actually didn't really click with me until I did my PhD. Like, I don't think you need to do a PhD. You just need to hear from other people and listen to, and read different texts and get sounding boards, do things like this, do the different student groups and that kind of stuff, and just hear from other people how they look at those kinds of things. And it's a process, and it takes time, and just recognize the clinician you're going to be at 1 year out is going to be way different than the clinician you're going to be at 4 or 5 years out. I don't know, did I answer your question, Reed?
Yes, sir. Yeah, I mean, I knew it was a complicated question, right? And there's a lot of facets to it, but it sounds like the take-home message is, first of all, kind of like what Ben was saying earlier, just understand that the things we're being taught in school aren't necessarily that cut and dry, right? That's step one. And then step two, it sounds like, is don't put this impeccable pressure on yourself as a student to, by the time you graduate, to be at this supreme level of clinical practice, because it's just not possible. But being comfortable with that journey of questioning things, learning things, and kind of feeling it out as you go along.
Yeah, one thing, Reed, what I would suggest is, even just like after something's taught in class, is just go, like, my door is always open to our students, and they pop in, and the problem is, like, they're just trying to learn the material to understand it for the test. Now, some of them, there's a few people in class that are like, really want to go deep and that kind of stuff, and so if I have that conversation in class, like, everybody's going to, well, okay, what's on the test? Like, and so what I tend to do is, I'll just tell that person, just come and talk to me after class. And then, so go and reach out to your professor or whoever. Feel free to reach out to me, and I'd be happy to talk. But, I think there's a lot of pressure on students, right? Because it's knowing the material, getting ready for clinical practice, passing the boards, and then it's also, okay, now I got to dig deeper. There's no relevance to this. What does that mean? And so, like, we purposely do, in our practicals, we do a clinical reasoning where we sit down one-on-one and they talk through a case with us, and they would say, okay, I would do this next. And then we give them findings. And, with the impetus is, well, okay, to see what their reasoning, why did they choose that, and defend it. And the problem is that takes a lot of repetitions. And so if somebody's uncomfortable, what they always default to is going through and doing a ton of special tests. And so they'll do, drop arm when they've already had, 4 out of 5 with the shoulder abduction test. And then we say, well, why did you do that? What did you find in muscle performance? And then they say, okay, yeah, that makes sense. But in the time, I mean, it's intense, right? It's Wolf's Law at a very intense time point. And to me, part of getting better is putting yourself in those types of situations, being uncomfortable, having somebody needle you. And I tell them this all the time. The last time you want to be under pressure is in front of me, right? Because like you're being graded. Go get in front of Chris and have him needle you, or get in front of Ben and have him needle you. And so when you come into the test, it's like, dude, I've been through this. Bring it. I mean, it just takes a lot of reps.
I would also say that I see a lot of students, they want to know the answer, but be aware that the answer that you learn now in 10 years may have changed, right? Because the research is going to change, things are going to go on. The key is really learn how to learn and learn how to continuously learn, because it's going to change. Your practice patterns are going to change. The literature is going to change. I mean, I tell people I used to cut people out of ACLs. Mike, I know you practiced long enough that we used to cut them out of casts. They used to cast ACLs. I tell students that and they're like, what the hell are you talking about? But that was a standard of practice at a point in time, right? So it's going to change. So learning to learn and being comfortable with having to learn and finding people that you can bounce ideas off and, hey, I'm saying this, what are you saying? And why are we thinking that? And having that rational thought process, because it's the understanding of things as they change. You're going to have to change with that. But if you think that you've learned an answer and you're done, then you're going to be well behind and you're no longer going to be servicing the people that are going to be in front of you. So it's constantly learning, constantly doing those things.
Yeah, and I would just chime in super quick. Like one thing that's helped me this semester in my MSK class is like switching my mindset up a little bit. From like at the beginning of the semester, just constantly questioning everything and being like, all right, this is a stupid special test, or like, why are we doing this stupid MOB? Because this is not great, or like, because I've read and seen things from people that I respect that are way smarter than me that refute some of these things I'm learning. And then I kind of took a step back and I'm like, all right, like that's not profitable. Like I think one thing that you said, Mike, that really resonated is that idea of patience, like, and that like you need to take the time to lay the foundation and understand the models of treatment that may have been updated in the future, but like doing so gives me so much more context. And like being able to just fully embrace, like my professor was talking about scap-tooth kinesis a couple of weeks ago, and the inner Chris inside of me was like, this is stupid, I'm leaving, it's so nice outside, this is dumb, like why are we talking about this? And then I'm like, all right, just like read the articles, take a step back, try to figure this out, and then see where you goes from there. And like I feel like that it's a little bit more refreshing, although sometimes like that voice on my right shoulder is always like telling me like find the answer right away. It's kind of like Paul said, like, this is not the answer, I need the exact answer. And like that mindset, I think it's helpful somewhat to question things, but it's such a balance and it's such a back and forth every day, especially coming from a prof who has a very strong bias towards manual therapy as well. And I have like a strong exercise bias, and it's like, it's a constant confrontation. It's not easy, but all the things you guys said, like I'd second everything. Like it makes sense, and it helps a ton having that context as a student.
Mike, since we fully derailed off the FAI topic, I have an off-topic question. Do students ever push back with what you're teaching, or is there ever, I don't know if confrontation is the right word, but there's, I think Ben alluded to it, I have very frequent, tiffs with my professors. So I'm curious if students at Duke have those type of conversations with you.
I mean, I'm sure, well, it's usually, yeah, I can't really think of big one. I mean, like I'm pretty honest with them and say, Like I don't say, okay, I'm teaching this because it's on the board. I mean, this is worthless. I mean, I don't frame it like that. Even though that's what I want to say sometimes. I mean, for example, like the SI joint is, I'll say, the evidence is not very good here, and I try to give what I think the best evidence is for it. We're not going to spend a lot of time. Like the only thing I teach them is the thigh thrust test because it's in Laszlo's cluster and it has 89% sensitivity. Actually, sometimes what I get more, well, what I worry about, and when they go out to clinical practice is like they'll be learning these different, things that I don't talk about, and things like PRI or whatever, and then they come back and like, I mean, like I try to keep them very evidence based, and they come back and they're doing all this. Who are you? Like I don't even know who you are anymore. Like you're doing K-taping and PRI. Like what happened to you? And but no, I'm pretty. I hope I'm pretty open, and like I'll tend to, like we've had some discussions in class where, well, like scoliosis is always a big one, and because somebody always in class always has scoliosis, and so it's like, should they have surgery? And I mean, we talk about C curves, S curves, Risser stages, and all this kind of stuff, and Scroth method, and all this kind of, and it's like I just like try to be honest, and they'll say, well, I think I need to go see somebody for this. And I said, well, you can, and you can get an opinion on this, but here's currently what the evidence shows. So, I mean, we do, but we're like, I have nothing to, I mean, it's no skin off my back if they look at things differently, and like I try to give them the evidence and have them make their own decisions. And I mean, I'm sure, like, well, I know there's students that have graduated that are big fans of particular methods, and like I kind of went off on one of them one time, and now this, I mean, the guy works for the Major League Baseball, and so the problem is now students see him, Major League Baseball, me teaching in front of them. Who do they look up to? They look up to that person, and so that's usually the bigger problem I have. I wouldn't say it's a problem. I mean, it's just difference of opinion, and yeah, we've had several interesting discussions, and it's usually pretty lighthearted where we like, needle each other in class, or like I sent out, I mean, I already picked on PRI, so I might as well go there. Like I sent this article on, well, and Geronimo posted it on Instagram about the Ober's test. Like when that first came out, Gib Willett published it to me. He's a good friend of mine. I sent it because they talk about using Ober's test for some of their stuff, and I sent it to. I talked about it in class, and one of the students that was big on PRI read the article and was trying to pick out some limitations on this. And I said, dude, it's a biomechanical study. Like, how wrong can it be? And so, but I mean, it created good discussions, and we sat in my office and just talked about it. So, which, I mean, I would suggest too, because I I'm starting to hear that's probably it's more on the other side, is like if there's some disagreements with a professor, is it's just, I would never suggest calling them out in class. I mean, talking to them in the office and just try, like I tell my students this about a CI. If like we had some CIs that have done, they're doing certain strategy, and it's against what I taught them. And I always suggest, well, I mean, I say you can use me, you can throw me under the bus and just say, here's what I learned in class, here's my understanding, and you're doing it this way. Like, can you help me connect these pieces, or see why your approach is, what is different here, and why might your approach maybe work better, and like just, I mean, use almost a motivational interviewing type of approach.
All right. Any last questions? If not, we can wrap it up. Yeah, just one quick thing. So, I mean, we alluded to a lot of Joanne Kemp's work, and that freak article, and the
systematic review from Diamond, and I think in a lot of those, and listening to Joanne Kemp, some of the stuff she talks about is like, if you look at a big cohort of younger athletes, you're going to see a lot of this CAM morphology going on in maybe anywhere from a third to 2/3, and then a third of those are usually asymptomatic anyways. And they're coming in at both preoperative, postoperative, and even long-term outcomes show that they've got, different degrees of hip weakness, however that's defined, different degrees of dynamic instability measured from these physical performance tests, a lot of some extrapolation from ACL stuff. So I guess I'm gathering a lot of info here and good stuff. Maybe if just to wrap things up, Mike, if you wouldn't mind, could you just give us like a 2 or 3 overarching principle, like walkaways from your message today that you'd like to see continue on for the next, who knows, 5-10 years in some of us younger clinicians?
Yeah, that's a great question. Yeah, I think the big thing here is just do a good comprehensive clinical exam, meaning, and not relying overly on special tests. So a good exam to me is, like, I teach what I call a funnel approach, which means you spend a ton of time on subjective exam. Even though the diagnostic accuracy is really poor or not even really looked at, I think, like, I usually have a pretty good idea after the subjective exam what I think is going on. The rest of my exam is either proving or disproving that. The rest of is what I found in the subjective history. And just listening to the patient, right? And then trying to take that information, looking at range of motion. I think range of motion is a big thing as far as FAI syndrome. Looking at the difference between IR and ER. And and then what is the infill? If I get, because like if you look at Duke's basketball team, they all have limited internal rotation. They all do. Now, is that relevant? That's the other thing, right? And so if I have limited internal rotation and I do contract relax and it gains like 10 degrees, like that's like, I'm not concerned. Like they can work on range of motion if they want to. My preference would be to strengthen through that range of motion. If I get to 0 degrees internal rotation and it's budding hard infill, like I'm not addressing that. I don't know what is. No, man. We'll find out tonight, I guess. It doesn't matter. Oh, I didn't even notice the UNC shirt. But yeah, I think. And here's the other thing: is there's a really nice study by Adrian Lowe. I don't know if you guys. I don't know if you guys know Adrian Lowe. The dude is awesome. He's such a funny guy. He's downhearted. But what he showed in his study is the clinical exam. He did a study where all they did is a clinical exam. And what they found out, and then they measured outcome, patient-reported outcome measures. So there are some limitations there. But what they found out is just by doing a clinical exam, the outcomes, they had some positive outcomes just by connecting with a patient, therapeutic alliance, touching a patient, those kinds of things. So I think that's why, whether an exam has good diagnostic accuracy, I think the big thing is it's a connection point with a patient. It's a therapeutic alliance point with a patient. And then I think you get some good information with range of motion and those kinds of things. I think the other thing is being honest with, like, I can do that. Paul and I can do this because we look older than you guys, but we can go into a room and say, you know what, I'm not exactly sure what's going on, but here's the things that I'm going to try. And don't be afraid to do those things. And, you might lose some therapeutic alliance being a student with a student in front of your name and your initials, but try to win that patient over. Because I still, like I said, as I get those patients, they don't want to be there. And the only reason they're there is the surgeon made them come before they can go to surgery. I love those challenges. Try to win that patient over without, BSing them and to say, you know what, I know squatting hurts, but we're going to try different ways. And it's important to me to know which way hurts and which way feels better. And if we don't find a way, we'll try something else. And so just being open and honest and say, you know what, we're going to try a few things, and and now we found is you can sumo squat and it doesn't hurt. So now when you go to the gym, that's what I want you to do. And so then that kind of drives your intervention. So I know that's probably more than 3 or 4 things there, but just, I mean, being open, being honest, and just utilizing the information that's, I mean, you're always gathering data and then making decisions on that data as you get it.
Thanks, Mike. You're my hero. You're the man.
I've just made a lot of mistakes.
Well, yeah, I appreciate all of the input you had, and enjoy your walk with your dog today. It sounds great.
Yeah, it's going to be beautiful here. Hopefully you guys have good weather.
Yeah, in
We
Texas.
do.
All right. Thanks everyone for joining. Thanks again, Mike. I'll see you virtually tomorrow as well.
All right.
All right. Have a good
Yeah.
one.
Bye.
Bye.